So I'll do that, and I'm going to share my screen. Everyone see my screen quite clearly?
You're good.
Oops, sorry. All right. Yeah, hello everyone. My name is Carmen. I'm one of the clinical informatics specialists with critical care at VGH. I'm joined by my manager, Nicole Wu, as well as the rest of my team, who I'll introduce in a minute. The purpose of this session is to do a requirements gathering of the General Surgery Rapid Access Clinic today. And again, this first session will be recorded to facilitate some note taking. I first want to do land acknowledgements. Today, we have the privilege of coming together on the unceded territories of Musqueam, Squamish, and Tsleil-Waututh nations. May we recognize this honor and approach our work with honesty, compassion, and understanding. We're just going to go over our agenda real quickly. So I'll first go through a few housekeeping items and introductions. Nicole will then go through some background information, including the purpose of the session, review of our guiding principles, and the role of a subject matter expert. We'll then go into our clinical requirements gathering, and we will confirm and verify workflows. We'll end off with an overview of our understanding of the clinic workflow, then answer any questions anyone might have for us, and then discuss next steps. So just some housekeeping items. Please mute when you aren't speaking. Please state your name when speaking to support proper meeting notes and follow-up items. Add any non-urgent questions to the chat, and this session, again, will be recorded. Just to introduce our subject matter experts, we have Dr. Sampath, who unfortunately couldn't join us today. He is our ACS provider. We have Baljit, who is the manager. Jonathan, who is our surgical project manager. Ari, who is a program assistant and clerk, who is shared with the CAS clinic as well, and Maria Torres, who is our wound care clinician. And my understanding there will be a second one hired on over the summer. Am I missing anyone from this list?
Hi, it's John here, project manager for Richmond. Not from our perspective. Thank you.
Okay. Thank you. I'll move on then. So our team. We have Nicole Wu, who is our clinical informatics manager of critical care and provider education. We have myself, Morgan, Alan, and Maggie, who is our clinical informatics specialist for critical care. We have Kirti and Rachel, who are ambulatory BAs and AA. Himanshu, who's a BA, Joshua, who's an AA on our scheduling team, Andy from our registration team, Editutu, who is from RSTQ, Tam from medication management, Elena who is our CST resource, Agnes, Jenny, and Doris from our order sets team, as well as Harmon from PET team, who is a PET team BA. Am I missing anyone on the CST team and informatics team side? If not, I will move on.
Sorry, quick question here.
Yes.
John from Richmond. Will this deck be shared to our team just so we can get familiarity with the team members?
Of course, we will be dispersing like the minutes as well as the slide deck afterwards.
Okay, perfect. Thank you, Carmen.
Yep. All right. Oops. So I'll just be passing over to Nicole to go over some background information.
Okay, sounds good. Thanks, Carmen. Okay, so the purpose of this session is really for us to gather the requirements and learn their current state of workflow. I know that we did a lot of this with yourself, Jonathan, when we went in for a little walkthrough. So hopefully most of this would have been captured in this session, but we do still have a few questions that we need to have answered. We also have our other teams on the call as well, just in case they have answered or questions that they have for yourself and anyone else on the call from your team. So there are a couple of sessions that we have going on. So this one's a requirement gathering session, which we're basically gather your requirements. And then from that, we will solution and design your future state based on what you've given us. And then we'll have a design session after that to confirm and review what we've designed out. We will make additional tweaks and changes based on the feedback we've gathered from you during the design session. Then we have a validation session, which is our final session to validate the content, the workflow, and everything that will be CST in our future state for you. In addition to these sessions, we also have scheduling and order set specific sessions. So scheduling for clinic scheduling, booking patients and things like that. We have a separate team that does this. And then order set specific sessions if the provider does any order entry that requires new orders being made or new power plans or converting the paper PPO to new power plans and modules and things like that. Anything that's out of scope will be added to our parking lot items and reviewed at these appropriate sessions. Okay, that's that. Okay, guiding principle. So as we go through our different sessions, we want to keep a few things in mind and have you keep a few things in mind as to what we want to do or things we want to build out as we move through this. So our first guiding principle in terms of our build is we don't change for the sake of change. We do it for a real and concrete reason. So it either has to be safety implications, patient safety implications, and that's why we want to change the system. Regulatory changes. So if there's regulatory changes or we're not meeting standards, then we'll change the system for that. Any financial reasons to increase financial efficacies without requiring significant operational cost implications, we'll make changes for that. And then obviously content. If there's a significant amount of content that's missing in our system, we will do design changes for that. But outside of these kind of 4 realm of things, we really don't want to change for the sake of change. There will be an opportunity to optimize the system after go live, but what we really want to make sure we get done is we're doing things that are important to us that really help contribute to the workflow and meet these requirements. Guiding principle 2 will be our focus is enterprise design. So as many of you guys know, we've already gone live at numerous other sites. We started with Lionsgate, St. Paul's, we've gone live with BJ's and numerous clinics before then. I know this clinic is generally net new, so there shouldn't be that many enterprise design that is specific to the clinic, but the overall workflow into other areas, such as into the OR spaces where you'll have your workflow flow to. We try to follow enterprise design as much as possible. And that's because we want to ensure that the patient care that's being delivered at one site is mimicked in other sites so that there's continuity of care and also ease of provider and clinician workflow if they have to move from site to site, that we're just not doing things drastically different. So we always try to do as enterprise design, and you'll hear that a lot for things that are standard across all health authorities. But for a clinic specific thing, let's say you have a very specific clinic workflow, then unless you have a similar clinic somewhere else, we will generally design for whatever your workflow is. And then the last guiding principle is, I think it's the most important, is really to prioritize what the must-haves and not what the nice-to-haves. And that really allows us to take the system live in a safe way where you have everything in the system you require for patient safety, for your workflow, to do your job. So we really want to focus on that, because if we let everything else come on board and say, okay, we'll design for everything and all the nice to have, we get overwhelmed. And with the multiple streams we have going on, it's not even feasible for our builders to do all this work. So to keep in mind as you go through this and you help us solution and build the system that fits your clinic, just really keep in mind, is this a nice to have or is this a must have? And we're not saying that we won't look at it. We'll absolutely look at the nice to have, but it's something that we'll do after go live. So after our go live period, we'll take a look and say, okay, how else can we optimize this? How do we make this better? But let's get us to the finish line with the must haves first. And role of the subject matter expert. So the role of the subject matter expert is, our experts are you guys from the site. And what your role is for us is to really provide us with the expertise and representation for your area, providing with the workflow and recommendation for your state. Working with Jonathan already last time, he's already done a lot of this, really providing us some amazing workflow and a video that he's already done. So lots of credits to him to be able to provide that for us, because that's what we need. We need you guys to really tell us what is your end-to-end workflow, what are the things that you do now, and we will work together to help solution those things. So really to help understand and think strategic about the process and workflow and consider other requirements and the needs of other stakeholder groups. So your role is to represent your peers, everyone at the clinic, your stakeholder groups, which includes your patients, and what is required from a clinical and technical standpoint in order to make sure that you can deliver the care you need to deliver. And for you to also be familiar with your health organization policy and documentation. We are familiar with the system, but policies around how frequently you need to document, what you need to document, things are like that will have to come from you, because every health authority is a little bit different. Even within the different sites within the health authority, sometimes you have different policies. We always recommend that you try to align the policies within your health authority organization as much as possible. We know that that's not always the case, but as much as possible, trying to align those things. So any changes in policies or alignment of policy across HO that falls on the site to do. And you are helping to make a lot of these decisions for your peers. And because so, we really ask that you be an advocate for these changes, an advocate for the design work, collaborating with the team, and just bringing back the information to the key people on your team, everyone else involved, anyone that has a skin in the game, really bring it back to them and let them know what's going on and promote the future state of what we're trying to do for your clinic. Any questions around that? Okay. Next slide. I think that's the end of my area. Carmen?
Okay. So now I'll be going into the clinical requirements gathering. We'll be going over what we know about the clinic. Please feel free to add any missing information as we go through. So clinic overview, we're first going to talk about the clinic description and its purpose. So what we do know it is dedicated for ED patients to reduce the waiting time for patients in the emergency department awaiting ACS surgeon consultation. It is also for the ACS post-op patients where it is a clinic for post-op patients to have follow-up appointments who previously fell off continuity of care due to the rotating schedules of the ACS surgeons. What we know for about the days and the hours is that it's Monday to Friday and it's 7 a.m. to 9:30 a.m. What we know about the positions is that there's an ACS provider, champion being Dr. Sampath. The ACS provider will change weekly and there are around 20 ACS surgeons. I just wanted some clarity on the official title for Ball, but are you a program manager? Like, what is your official title?
You want my official title?
Yeah, I just for purposes of like, so we know what your official title is.
I shouldn't say ruler of the world. I am the perioperative manager
Okay,
perioperative services manager and the director for the surgical program.
okay, thank you so much. We will update the slides so and our information so we have that down now.
Yeah.
Yes.
One quick point of clarity here. So
Yes.
the project is still, I mean, the clinic is still in the project phase, so it hasn't officially landed within a portfolio,
Right.
but very likely it'll land within Bel's portfolio, as you mentioned.
Okay,
Yep.
thank you. And then we have Jonathan Chung, who is our surgical project manager, Ari Arello, who is our the program assistant, as well as the clerk, and Maria Torres, who's the wound care clinician. From our list earlier, it doesn't sound like anyone is missing, so I will move on. Next, we'll just ask about electronic medical records systems that are in use. So what we know is that the clinic currently uses PCS, CareCast for registration, Outlook for scheduling, as well as Care Connect to gather information. Just what we need to know is, are there any other EMRs that are used, and are any custom built system to document or access, are there any custom built systems to document or access patient information that are used?
No, not for a moment. Outside of these systems, there's paper and fax, but otherwise there's no EMR, anything
Okay.
else.
Okay.
Yeah.
And okay, thank you. And no use of any databases as well. Is that correct?
The only database and the only data point that we do track is volume, based
Okay.
on PCIS code, and that's with decision support.
Okay.
Yeah.
Thank you. Moving on, we're going to talk about referrals and triage. So what we know about referrals to this clinic is the patient always requires a referral. From the outpatient side, this is received from ED via ED referral form, and we'll go into more detail about this in the next few slides. This is just a very brief overview. So commonly by fax, documents that accompany from the ED referral form are also the medical and surgical history, relevant investigation results, and ED notes, as well as a medication list. For the inpatient side, these are ACS post-op patients who have their discharge order for the follow-up in GRAC faxed from 3 North. And so the ACS surgeon manages all these referrals for GRAC. My only question with this is that, are there any other types of documents that are included with the referral form from the ED as part of the ED referral package, other than what I have listed there?
No other standard types documentation or information included outside of what's listed. But
Mhm.
if there are any particular like specific tests or results for the patient, then they might be included within the ED referral. But that's really specific to the patient and the type of issue that they present with.
Okay, thank you. Moving on, so some of these are questions and I will be very specific, but the information we'll be going through is just either to confirm or I will be asking questions as well. So what we know is that patients referred from ED, the ACS providers consulted theirs in ED or post-op inpatients, which is just reiterating the last slide. And the ACS provider manages the referrals. The priority is determined by the ACS provider, who will specify whether it's next day, same week.
Sorry, point of clarity there.
Yeah.
The priority is determined by the ACS provider in conversation with ED.
Okay.
So it'll be a collaborative conversation rather than just solely on the ACS provider.
Okay. Thank you. And so once a referral is accepted, any labs or diagnostics will be completed by in ED before sending the patient over to GRAC. I did have a question. If patient needs further investigation, like a scope, as we discussed before, this patient's discharged and an appointment will be made with GRAC afterwards. I just want to know what this looked like. Would the provider refer them to another clinic to get this done? Will they be admitted just to have this procedure or this diagnostic test done? Or would it depend on the urgency of the case? I just wanted a little bit more information on that.
For sure. Yeah. So depending on the type of investigation, if it's blood work or medical imaging, it could just be included as a pre-op order. So the patient can, depending on the timing of the surgery, the patient can just go to the services needed and have those done before surgery. However, if it's of scope, I guess there are really two main pathways for scope. If it's an emergency scope, the patient will be admitted as an inpatient, which then enables emergency scopes to be ordered for the patient. However, since this patient as a GRAC patient is an outpatient clinic, is an outpatient. If there are urgent scopes needed before, then they would be officially discharged from GRAC. They'll be referred to one of the surgeons' scopes list, wait list.
Hi there, how
And
are
then
you?
once,
Yeah, I can tell. It's okay. So I'm calling from
sorry,
what's
you can mute that if you need.
I'm the director for the surgical program.
Yep.
Okay, so
sorry.
Yes, no, you're good. So then, where was I? Urgent scopes, right? So the patient will be officially discharged from GRAC. They will then have their scopes done, and once they're done, the patient would then be called back to GRAC. So likely, like the surgeon themselves would know that this is a GRAC patient waiting on scopes results, and then the surgeon will then book them back in GRAC for the next appointment.
Okay.
Yeah.
Thank you. Okay, and my understanding is there is no wait list for GRAC. That was the last point on this.
No wait list. Yeah, no. It's
Okay.
either next day or within the same week.
Yeah.
If you count that as a wait list, but not really.
Yep. Okay, thank you. Next, we'll move on to scheduling. So what we do know is there's no unique scheduling process or exceptional workflows, which we'll get into. So we know that you guys have one clerk, which is shared with the CAS clinic. The GRAC program assistant clerk will book these same week referrals and inpatient follow-up appointments. Next day referrals go straight to RH main admitting at 8 o'clock. Is that correct?
Yep, that's correct.
And then there are no private secretaries or MOAs. And no other clinic should be booking into GRAC.
Yes. and no. Yes, I
Yes,
guess in
technically,
terms
yeah.
of process, yes. But referrals from other clinics can happen.
Okay.
It'll just be a referral process.
Yep.
Yeah.
Sounds good. And then just again, just a lot of reconfirming details, but
Go for
registration
it.
is done by Richmond Hospital main admitting. All schedule is done by clerk or program assistant. The patient check-in is shared between kind of RH main admitting and clerk because they both have to check in their patient with different things. Is that correct?
Yeah, that's correct. Yeah.
Okay. And then this is a question. Do you currently schedule requests or coordinate any appointments with any other clinics or departments for your patients? Like kind of like with this, I guess not like if they had if they ended up booking a scope and then, they would book a GRAC appointment right after. Or I guess that actually wouldn't work, but just anything like that type of thing, coordinating with other departments or clinics.
No, logistically, it's quite hard for us.
Yeah.
And I think for that reason, we forgoed that.
Okay.
So effectively, each visit is intended to conclude within that visit.
Okay.
So if it's either they go to surgery or if they go on to the next clinic or whatever requirements they do need, but we don't coordinate with other clinics to fit that element in the schedule or some clinic. That's outside the scope of the clinic.
Okay.
Yeah.
Thank you. And my understanding is there's no use of automated appointment reminders currently. All the appointments are through Outlook. And the appointments are basically booked under a week. And then follow-up timeline for post-op patients are a little different and they would be under a month is my understanding. Or there's no timeline per se.
There's no timeline. We don't really specify a specific timeline, but most follow-ups do tend to happen under a month.
Yeah.
If that is needed information, but we don't say like, oh, you can't follow up after 2 months.
Okay.
Yeah.
Cool. Thank you. Moving on to the next slide, more about scheduling. So just confirming that there are around 6 to 12 patients a week. Appointments are currently scheduled as a series in PCIS, and then a need for another appointment is determined at each appointment, and that will be communicated from the ACS surgeon to the program assistant. This is a question for you guys. So do you ever schedule or coordinate support staff for external to your clinic? The most relevant one I thought might be interpreters, if this was ever maybe
Interpreters, like you mentioned. All the others, not that I'm aware of, or not that we have planned, but interpreters do happen as needed basis.
And at Richmond Hospital, is this just a call to the service?
Yeah, I believe there's like a booking system,
Okay.
and then we just book it as per. But we also have the mobile translator tablet.
Oh yes,
thing.
yes, I'm familiar with that as well.
Yeah.
Okay,
So
thank you.
the device. So it's between those two.
Okay, thank you. My understanding is there's no walk-in patients and it's referral only. And the program assistant will book an appointment once she receives a referral either way, always through the fax or from either ED or the discharge order that's faxed to GRAC.
Yep.
Yep. And then there's no written order other than the fax referrals that are received. Like there's no order that okays to schedule or something.
No.
Yeah.
No, it's a conversation with the surgeon, and then the form will just be faxed.
Yep. And then the follow-up for the patients who no-show for their appointment, it would just involve the clerk following up with the patient with a phone call.
Yeah, that's correct. Yeah.
Okay, so moving on. Last slide about scheduling. I believe I already mentioned this earlier, but all patients will go to RH main admitting first to be registered, and then they will check in with the clerk at GRAC afterwards.
Actually, they don't check in with the clerk afterwards.
Okay.
Yeah, they essentially once the patient's checked in at main admitting, the surgeon receives the patient at the clinic, and then once the clinic's done, the patient will leave. They don't necessarily have to check in with the clerk. The surgeon will often check in with the clerk afterwards, but not always.
Okay. These questions come up later as well, so we might just skip it then. But if there were 2 intake forms that the patient has to fill out, are these usually given by RH main admitting then?
Can you specify what the intake forms are? Like any,
Yes, maybe I'll bring it up later because I actually have like the actual form.
okay. No, yeah,
So
go, yeah.
I will
Yeah.
bring it up again then.
Mhm.
Just more questions, but are there just double checking, but are there any unique scheduling process or exceptional workflows that we should be aware of for your clinic?
Yeah, essentially in PCIS, we have the location code, but we don't have a scheduling template, hence the use of Outlook to schedule, which is not optimal at all. So we're hoping to have that addressed through CST.
Okay. And then any hardships, major, minor, and I guess that is your hardship
That is a very
with your scheduling
hard,
process. Yes.
extremely hard thing for us to address. Yeah.
Okay. And then just confirming again, do you guys use any like virtual health, do any virtual health appointments like telehealth, video, or like Zoom or telephone, and or is it always in person?
In person, most of the
Okay.
times physical examination is required, but we may look into virtual health appointments for follow-ups as needed.
Okay, so it might be a possibility. Okay, thank you. Moving on. Just a few questions about health information. So what we know is that paper documents received in your clinic via fax, usually fax, are sent to health records for processing storage afterwards. Is that correct?
Can you clarify? Like, are you talking about the referral form?
I think just the information package that you guys receive in the by fax, basically.
For sure. Yeah. So realistically, I think while that we have discussed that that's the requirements, most of the time that information does exist on PCIS. So the
Oh,
physician
yeah.
would just access it through there. And I think any paper documents, they're sent towards health records. And
Okay.
yeah, but most of the time now, I'll let Ari speak to it when she returns and I'll make sure to follow that up. But most of the time we do just receive the referral form. Yeah.
Okay.
Mhm.
Okay. Just more questions, but let's see. Do you? Let me see. It's more this last question. Is there a chart kept for patients, like physically in GRAC?
Not in GRAC, no.
Okay.
No, a chart's not really created for the patient until they go for surgery.
Okay. Okay. Thank you. I will move on then. So these are the documents then, which we'll talk about next. So yeah, the ED referral form, and then these are the other possible like documents that may come with the ED referral form. And then the other documentation you guys use is if the patient is being booked for OR. So you have the emergency OR booking slip or the community OR booking package. Is this correct?
Yeah, those are essentially the two booking packages.
Okay. I believe we kind of already went over this first question. So, which are like what other documents you receive in your fax line? I do want to ask though, does the clerk or anyone scan anything in at the clinic?
No.
Okay. And we went over that. And is there any like document that you guys share on a G drive that you guys print out and use, like the clinicians use?
Well, we have the package which we print out, but
Right.
other than that, there's not really anything that we share with the patient that is from a central drive.
Okay.
Yeah.
Cool.
There's
Thank
a
you.
lot of verbal instructions and communications.
Okay, thank
Yeah.
you. Okay, and we're going to go into what the day of visit will look like for the patient and as well the clinicians they interact with. So I'm going to pass this over to Morgan.
Thanks, Carmen. So again, just going over a bunch of questions related to check-in to begin with. So first things first is we just want to talk about your patient check-in process. So the patient, as we understand, checks in with main admitting, and then they are registered in PCIS. They are directed, or you just said that they don't need to check in with the clerk. So in that case, where do they receive their pre-admission information form and questionnaire? Is that from main admitting?
So they're actually, when Ari books the appointment, the forms will be sent out for the patients as well. But I think a lot of times they're actually filled in with a surgeon within a consult. So if the patient comes with it filled out, that's great. That's really helpful. But otherwise, it's there's not really a location where we hand out the form and ask the patient to fill out before the consult.
Okay.
Yeah. And as you mentioned, like there is no need for the patient to check in with the clerk before going to the to GRAC.
Okay.
Yeah.
In terms of where they go when they arrive at the clinic, so we were able to see the physical location when we came to Richmond to meet up with you. So we're just wondering if there is anywhere else that they need to go, or they just wait outside the consult room.
That's it. They just wait outside. And I do have to call out that we may change the location of the clinic. Not a major change, but it's just from 1306A to 1306B. Just
Okay.
right next door. Yeah.
Okay, sounds good. In terms of check-in with the scheduling clerk, so if they're coming back for like a follow-up appointment, would
Mhm.
they be seeing Ari then, or is it only like they skip over her during the first visit? If they come in for subsequent ones, are they going to check in with her? Or when do
No, it's same process, but the surgeon was communicate with Ari to book a follow-up.
Okay. And she completes both the scheduling and the check-in?
I guess more accurately, the main admitting will be checking them in.
Okay.
In that sense. But yeah, the RE will finish the scheduling and she'll backfill the details on PCIS.
In terms of who the first point of contact is with the patient in the clinic, we understand that it would be main admitting, and then they will wait outside the consultation room, and then their next contact will be the surgeon.
Yes. Yeah.
Okay. Do they get an armband? We understand that they do not. Is that correct?
They don't. No.
Question, how does the clinician know when the patient arrives? Do they just poke their head outside and see if the patient's waiting in the hallway?
Pretty much, yeah.
Okay.
So every day at 7 a.m. the RE will prepare like a slate for the clinician to see. So roughly they know when the patient should be coming in.
Okay. And they'll just
Yeah,
keep.
so every day 7 a.m. they'll have a rough schedule, and then around that time they'll know to poke their head out of the consult room to look for them.
Great. Okay.
Yeah.
And then in terms of intake / questionnaire forms for the patients to fill out, they have the 2 intake forms and they get that ahead of time.
Yeah.
And then admission screening would be done in ER or inpatient, depending on where they're coming from. If they're being
Yeah.
to
Yeah. If
inpatient.
they're being admitted, they'll go through the ER or inpatient process. I think within GRAC, it's not strictly a process that we go through.
Okay.
Oh, sorry, the recording stopped. Did it stop? Okay, anyways, sorry. But after the surgery, there'll be like post-op notes and inpatient notes, discharge notes, all that stuff, which is outside of GRAC's scope. But if the patient has a post-op follow-up, the GRAC physician will make an outpatient note, clinic note.
Okay. And then that gets sent to health records later?
It will be recorded through, I think, a modal, which then goes to Care Connect.
Okay.
Yeah.
Great, thank you. Who reviews the chart prior to the appointment? So it would just be whoever the ACS surgeon is that's on rotation at that time.
Pretty much, yeah.
Okay.
Mhm.
And then does the clerk complete chart prep prior to the clinic? As we understand, the ED will process the referral packages and
Mhm.
information through PCIS and Care Connect, and then they will prepare a blank OR booking package. Is there anything that we're missing there?
No, nothing. That's all.
Okay. Do they take any pictures that need to be included in the patient's chart? For example, like wound care or like wound images?
I think this is a question more for Maria. So Maria, I'm not sure if you had this experience before. This is not standard practice, but this may be a practice depending on the surgeon.
Sorry, I missed the first part of the question.
Yeah. Well, I think the team's just wondering if there's ever any pictures taken that would be included for the patient chart.
Not currently, but if the technology is available, then it would be good to have.
Yeah. I'd say for now, it's definitely like it's not really in consideration given what we have. But if it is, as Maria said, if this is a possible future option, then I think it'll be utilized more.
Okay. Cool. Do you use any other external documentation systems such as Muse, Hardiz, ProMiz? We know that you use PCIS/CareCast. Are there any other ones that we're missing?
Sorry, can I clarify what's CareCast? Is that same as Care Connect?
Yeah, sorry.
Okay, no, cool. Yeah, that's it. Yeah.
Is there any sort of routine follow-up interval, 3 months, 6 months, and so on, or is it just on an as-needed basis?
As needed, realistically. And sorry, going back on your previous question, it's I guess there's also a modal for us. But I
Okay.
guess it all ties in together. Yeah.
When the patient is discharged, they will receive the waiting at home for surgery information package. Do they receive anything else in terms of documentation?
No,
Okay.
not for standard procedure.
And then we're just wondering a little bit more about the patient departure process. So we talked about this previously. And so we were just wondering what the difference is between a community surgery slate and an elective surgery slate. Because
Mhm.
it looks like the surgeon within the elective surgery stream, the surgeon will refer to the general surgeon. But is there a difference between that surgeon and the general surgeon?
Sorry, I guess what I can do is I can talk through each stream of surgery and then we
Sure.
can circle back if there's any questions. So for emergency surgery slate, that implies that the surgery has to be done within a day. If not like the next day immediately, but most of the time will be within the same day. So the surgeon completes the emergency surgery slip. They'll walk it over to the front desk and they'll organize all the details, including the they'll call bed control for all the organization and pieces and all that stuff. But the patient will have the surgery within the same day. For community surgery slate, it implies that this is an urgent surgery, which the patient will need the surgery as soon as possible, but not within the same day. So in this instant, the patient will be discharged from GRAC, they'll go home, and then they'll receive a call whenever there is availability on the surgical slate to accommodate their surgery. So this can happen within the same week. So for example, if I go to GRAC on a Monday, I need community surgery, I'll go home. And then perhaps on Tuesday night, I will receive a call to say that, hey, Wednesday, Richmond Hospital has a slot or availability to do your surgery and then I'll have instructions to fast and to come in at a certain time on Wednesday to have my surgery done. For elective surgery, this implies that there's not as much urgency within for the patient to have their surgery done. So this then gets added to a surgical booking list. So depending on which surgeon, which surgeon's clinic it gets assigned to, they'll have a variety of wait list times. But I guess the caveat to this is ACS surgeons at Richmond Hospital, they do not have privilege to do elective surgery. Hence the reason and the specification to say that they have to refer the patient to the office of a general surgeon on call.
Oh, okay.
Yeah.
Okay.
So I guess to answer your second question, ACS, what's the difference between ACS and general surgeon? So I guess to clarify, general surgeons within the context of GRAC refers to the subset of general surgeons who have at Richmond Hospital who have privilege to conduct elective surgeries. And then for ACS, this is just really they've contracted and they've received, I guess, privilege to do only acute care surgery, which GRAC patients are bracketed under.
Okay.
Yeah. And I guess outside of GRAC scope, ACS surgeons would typically do the emergency cases, the consults coming from ED and that kind of stuff. So that's the slight difference between them.
Okay, great, thanks. Carmen, did you have any other questions about this slide?
No, thank you. That was very helpful.
No worries. Sorry, I also missed the first question there. So where the patient gets directed to, for emergency surgery, the patient will be referred to surgical daycare to wait for the emergency surgery slate. So after GRAC, they'll walk over to surgical daycare, and then they'll wait there until the time of their surgery. And as mentioned, for community surgery, they'll go home, and then on the day of their surgery, they'll present to surgical daycare. And then for elective surgery, that's organized by the office of the general surgeon, and they'll go out to their private clinics. And then for the last one, inpatient admission, as it kind of lists there, it's really dependent. We'll have the patient move to a monitored area. So it could be surgical daycare, it could be PACU, or it could be ED. And it'll be a temporary before or until an inpatient bed is available for the patient to be admitted.
Yeah, thank you. You answered those two questions perfectly. I have no further questions for these two, for this slide at least.
Great, okay. Let's move on then. Okay, so this is more questions for our lovely wound clinician who's joined us. So we're just wondering if you could briefly describe the clinical nursing tasks in the clinic. Do you do any point of care testing, or is it mostly just assessment?
Yeah, it would just be typical, it'd just be assessment, but yeah, wound assessments in particular.
Okay, perfect. What kind of documentation do you normally do? Do you have a form, or is it just kind of like nursing notes?
Usually I would document in progress notes.
Okay. And in terms of what you document, it's just your assessment, dressing changes, how the wound is healing, that kind of thing?
Yeah, correct.
Okay, perfect. Do you need to document any allergies, home meds, or histories, or is that just done by ER and inpatient?
Sorry, what was that last bit?
Do you need to document any allergies, home meds, or histories, or is that mostly done in ER and in inpatient?
Yeah, that would generally be done in ER unless something would come up in my assessment.
Okay. Do you use your own slate or schedule for the clinic, or how are you scheduled in essentially to come and visit someone in GRAC?
I guess it would be through a consult.
Okay, how do they consult you? Do they call you, email, fax?
Right now, so I've only seen like 1 or 2 patients there right now, and it's been through a phone call.
Okay. Do you have any other clinicians that you work with as well that you share your patient load with?
I do, but she's not here. She's on mat leave and she won't be back till December.
Okay, so right now it's basically
It's just me and my other clinician, my other coworker, but she's only here temporarily.
Okay. So is it only you that is visiting patients in that clinic right now?
For the moment, yeah.
Okay. Do you know in the future when there are more of you working together, how the workload is going to be distributed, or how you're going to organize that?
I mean, I mean, it's a bit like, even though there's going to be just more than one of us, I think we're going to have a shared list, I guess. It sounds like.
Okay.
Yeah, and then it would just be like a shared list, and then we would just distribute the workload depending
Okay.
on our triage.
Do you have any idea what this list would look like, or what kind of, I guess, program it would be using? Like, would it be Outlook?
It would be through Cerner is my guess, right? Because I mean, we would work like the VGH team would work, right? Like where we have a team approach. So that's my thought. That's what I'm imagining it's going to be. Right now, it's just verbal, like we verbally kind of discuss our patients and, triage them. And we do have our own manual handmade list. So yesterday or Tuesday, I was in a CST meeting, and it sounds like there's going to be some kind of a shared list that's generated through consults through Cerner.
Yeah.
Is my understanding.
Just for current state, you're using paper then?
Manual paper, yeah.
Okay. Cool. Do you call your patients in between clinic visits for a follow-up at all?
For outpatients, no.
Okay. If the patient has any concerns or issues in between clinic visits, how is this communicated to the providers? As we understand it, patients are directed to call the clinic or to go to the ER if it's urgent.
Yeah, from my perspective, I don't really run an outpatient workload because I'm only like clinician for the hospital. So I don't have the capacity to just kind of like, I don't have the capacity to manage outpatients. Does that make sense? Like aside from them being consulted into a clinic.
Okay, perfect. If the patient visits the clinic and they require a new prescription, who would complete the refill? Would it be the surgeon?
Yeah, I don't prescribe.
Okay. And do you need to administer any medications at all?
I wouldn't think so.
Okay. Do you ever need to give like analgesia or the dressing change or anything like that?
Inpatient potentially, but typically outpatient, it would be, you know, the physician would have to order it and then potentially I would administer it, but
Okay.
it hasn't come up so far.
Okay. Okay. So it hasn't occurred at all in GRAC yet.
Not yet. No.
Okay, great. Okay, let's go to our next one. Okay, no medications, so we can skip over that. No pharmacist at GRAC, is that correct?
That is correct.
Do you administer any cytotoxic or biologics? As far as we know, no, but just
Nope.
wanted to confirm. Okay.
Yeah.
Okay, I'll pass it back to Carmen for this part.
Thanks, Morgan. So what we know about the role of the clerk is that they are also the program assistant, and it is a shared resource with Class Clinic. The working hours are 7 to 3 p.m. They process ED referral packages and discharge follow-up orders, and then they will schedule and book appointments in Outlook, which includes contacting the patients. They prepare the clinic slate for the ACS surgeon in the morning, so they have a list of all the patients that need to be seen. They prepare patient information through PCIS and Care Connect. They prepare blank OR booking packages if needed. They input clinic appointment details in PCIS after consult. They follow up with patients who no-show, i.e. they'll call them. And they'll provide patients with departure handout as needed. This one I'm not sure about.
Ari doesn't do that.
She does not. Okay.
No,
Is
the
it
instructions.
surgeon?
Yeah, the surgeon will hand over and communicate any instructions regarding surgery or procedures.
Okay, thank you.
Mhm.
I just had a few questions. So I was wondering what information is actually gathered by from Care Connect and PCIS.
For sure. So I guess for the first question, there's never any requirements for RA to prepare. This is just more on her own prepare for her own volition. The information is mainly to see if there's any referral notes or any other note documentation that could supplement the surgeon with more background information and context, but no particular information. That is standard procedure for RE to collect.
Okay.
For PCIS, sorry, does that answer your question? Or?
Yes, it does. Thank you.
Cool. No, here's so for the information.
You're
good. So for the information that is entered in PCIS, that is mainly patient demographics.
Okay.
Yeah.
And
then current format of the clinic slate is paper, and that's also by verbal / text communication.
Okay.
Which is again not ideal, and why we need to address that hardship.
Yep. Sounds good. Thank you. And we understand that there is no allied health who work with this clinic. And for the provider, what we know is that the ACS provider on rotation will see the patients in GRAC. They will receive the clinic slate from PA / clerk. Patient appointments in this clinic at least are from 7 to 9:30 a.m. They will review patient, then dictate using M-modal. They determine the next step, which include the four departure pathways that you have described before. I will not repeat those, but is this correct? I do have a slide of questions afterwards.
I guess the next step, okay, yeah, that's pretty much the four main pathways that it could happen. It could theoretically, the patient could just be discharged and follow up without any action, but from our perspective, it just means it's a discontinue of one patient journey, and it'll be reintroduced as needed. So the 4 are correct
Okay, thank
and
you.
accurate.
Thank you. It was from your very well-made resources, so thank you. So next, I just have a few questions or things to confirm. As we mentioned earlier, the ACS surgeon on rotation that week will review and manage patient results. My understanding is that there's no prescription that will be prescribed from this clinic. Is that correct?
Prescriptions as in
Like a
outpatients?
new prescription. I guess my question is more like if
For post-op, right? Effectively.
yeah, I'm
Um,
assuming like inpatient, they would have discharge, like prescription, and from ED, if they were in any type of pain that might have been addressed already. So in GRAC, would they ever be written a prescription?
So I guess from the start to beginning,
Yeah.
sorry, start to end, sorry.
Yep.
From the ED side, as you mentioned, they might have already have some prescriptions for as they were discharged and waiting for the consult.
Mhm.
And then there's also within the OR package, there could be medications or pre-surgical orders, right?
Yeah.
So I guess to answer your question, that might be one part that plays into it. And then as you mentioned, from an inpatient and discharge perspective, they would have prescriptions. They'll likely have medications at that point. And then I think at GRAC, they might just review those, but I think that prescriptions are not commonly given since they already would have medications from discharge.
Okay. Thank you for clarifying that. And I understand that there are patients that will be directly admitted or transferred to emergency department, as we discussed through those pathways.
Not ideal, but it can happen. Yeah.
And do the ACS providers ever refer to other specialists? I think it was kind of alluded to earlier that they could.
They could.
It's
So
like
I
if
guess
they needed something else to be done prior.
for sure. The two main specialists or
Mhm.
the two main other types of offices they can refer to is one, the general surgeon's
Yeah.
private offices for elective surgery booking. And then 2 would be the scopes, and that would go towards ambulatory care, and it will just go into the endoscopy unit.
Thank you.
Mhm.
That answers my next question. So then this might be more for Dr. Sampath, but would they establish themselves as a primary lifetime specialist? I understand that it might be determined based on if it's like a chronic problem versus a very acute problem. That's a one-time thing, but would you know the answer to this? Or maybe that is the answer.
I think Dr. Sampath will provide a more official and accurate
Okay.
answer. But from our perspective, GRAC is a one-time emergency clinic. So in that sense, we're not meant to have patients who, well, I mean, we shouldn't say that. We ideally do not see patients who are coming in repeatedly or routinely. We are mainly to decant and also to address the urgencies.
Okay. If this would also be a question that I can direct to Dr. Sampath, but do you think it would be beneficial for him or the ACS providers to be notified via CSD Cerner when the patient is admitted to the inpatient or ED?
I think that would be a question for Dr.
Yeah.
Sampath.
Yeah,
I
so
will do that.
sorry guys, just following up. So for the patient, the expectation would not be that they come back and see the clinic multiple times. It's kind of just like a follow-up. It's either a pre or post follow-up from a surgical procedure. And so they wouldn't continually be seeing that surgeon in the GRAC, right? So it's likely going to be maybe a one time, maybe a max 2 time, depending on if they're being seen pre and post surgery. And then the second question you had, would they like to be notified if the patient comes back for surgery or admitted again? So yeah, you can ask Dr. Sampath that, but I'm going to presume the answer will be no. And the reason is because these are locum physicians that are typically running the ACS or GRAC clinic, which means that they may not be around, right? So they likely will not be following the patient again anyways. And we wouldn't send the notification to all of the surgeons that are part of the ACS.
Exactly. I think because of the rotation program for both of those Again, I think Dr. Sampath would be best to provide the answer, but from a rotation perspective, it's just very hard to track that. And I don't know if there's specific benefits for them to know.
Okay, thank you. That's very helpful. And my next question is not really a question because I already know this. So if another follow-up appointment is required, the ACS provider will let the program assistant know and they will book.
Yeah, exactly.
And then this is a question though. Is there any other discrete data being documented elsewhere that is being used for research?
No.
Okay, I will move on. I did schedule in a little break for if anyone wanted a bio break. I just want to let you guys decide. I can move on.
I'm okay to proceed. I just want to check if Val, Maria wants that
Yeah.
break, or if any of your team wants a break.
Yeah, I do recognize it's quite a long meeting, so.
Let's proceed. Sorry,
Yeah.
Maria, I see your mic's off.
Okay.
You're good? Okay, great.
Yeah.
Let's proceed. And then if needed, we'll just step away quickly.
Yep.
Needed. Thank you.
Sounds good.
Thank you for scheduling it.
Yes, no problem. I will move on and I will be passing the next to Alan to talk about procedures and treatment.
Hi, everybody. I didn't have the pleasure of joining Morgan and Carmen and Nicole on their visit to GRAC, but I'll feel free to jump in, my colleagues, if there's anything that I'm missing or anything that I'm overlooking. But hopefully this next part will be fairly straightforward. So just move on to the next slide. Thank you. So I'm going to ask a few questions about procedures and treatments. So this is our understanding of the current situation. So the wound care clinician is pre-booked or consulted over the phone by ACS surgeon. I think Marie confirmed that earlier today. The wound care clinician reviews and completes wound dressing changes, and this is done within the physical space of the clinic, correct?
Yes.
Okay, perfect. So my question next is, how is this this documented, and how do you keep track of your? So how do you keep track of your appointments that are booked? It sounds like when I heard before that it's paper, you just kind of write it down on a piece of paper, and because you're the only clinician, it's pretty easy to do currently.
Correct.
Perfect. Okay. And then in terms of the documentation required, do you have a specific BCH standard wound care flow sheets that you're using to document on?
We do have standard flow sheets, but for my assessments, usually I do them longhand.
Okay, perfect. And then you said that you file this in progress notes. Where are these progress notes kept?
You mean for the ACS clinic here?
Yes, correct.
It would just be in the yellow history sheet notes, whatever chart they have there, that's where it would be documented.
Okay. And then are these procedure notes distributed to other clinicians involved in this patient's care?
Not as far as I know.
Okay, so this documentation is primarily kept for the patients when they come to you within the clinic and used primarily within your clinic then?
Yeah, I think the only time that I could see my particular notes being shared is if a patient needs community nursing support, and then they would need to have that information of my assessment and care planning shared.
Thank you, Maria.
Yeah.
And then are some subsequent follow-up appointments determined by you at the time after you assess as well? And you would communicate this to RA to book follow-up appointments for this wound care?
I don't know if they would bring them in just for wound care. I think at this point, the goal is just for the surgeons, and if they need my support to come down and support them with the, dressing management per se, and then if it's a need for them to be seen in community, that would be, I think, ideally the goal.
Perfect. So it sounds okay. Perfect. And you don't take part in booking any community follow-up. That's not done through your clinic then, I understand.
No, we're just ironing out that process, but I suspect we're leaning towards using our transition nursing is what it sounds like.
Okay. No, thank you very, very much for that, Maria. Perfect. And then on to the next slide, I'm going to ask a few questions about laboratory diagnostic testing, but I think a lot of these issues have been covered before. But what we know is that lab and diagnostic orders may be ordered as part of the OR booking package. But as of right now, no labs or diagnostics are actually done within your clinic itself, correct?
Uh, I guess a specification to that is if the clinicians require labs or diagnostics, they can order it.
Okay.
So the patient can be sent for lab blood work or diagnostics needed if they need to use that information before determining the feasibility of surgery. So I don't think that's as accurate. So it can
Okay.
be ordered. Yeah.
Okay, that's actually very good to clarify. Thanks for calling that out,
Yep.
Jonathan. So if that's the case, so ED patients have their labs on ED. So in the case so in this case you described, you have a patient coming directly to GRAC, and then they can get the testing done from there. But they'll likely go to other parts of the hospital to get this testing done, it sounds like.
So I guess two parts to this. So when they're referred from ED, the expectation is they'll have their lab work and diagnostics done before the referral is completed. So that'll be a part of the referral process. And then if further bloods or diagnostics is needed when the surgeon reviews the patient in the clinic, the patient can be sent to outpatient labs or diagnostics to have that done. And then as well, these can be ordered as a part of pre-op orders before surgery.
Okay, so I think that that's a few questions here. So do the post-operative patients who are coming for follow-up appointments, do they require lab work to be done prior to coming in for their follow-up visits?
Not to my knowledge. I think this might be a question for Dr. Sampath.
Okay.
Yeah.
Okay, in which case we can kind of skip over that next point, but where this is done. Okay. I think we've already addressed it. The patient is asked to come to the lab for specific tests, or they might be referred to. It sounds like the ambulatory clinic for endoscopy. But I think you answered that piece here.
Yeah. So yeah.
Perfect. And then I guess you don't know about in terms of like outpatient lab requisition. So maybe we'll follow up with Dr. Sampath about the next few questions here.
That would be best. I believe most. Sorry, I shouldn't say that, but I think the patients can utilize the lab services we have at the hospital.
Okay, perfect. But it's not common for, say, like a lab tech to come into your clinic itself and draw blood directly or draw lab samples directly for your patient while they're no. Okay. Thank you very much for that. Perfect. Why don't we move on to our next slide? Okay. And then similar to what I asked about with respect to lab work, similar questions about diagnostic imaging. I imagine if they come through the emergency department, all their diagnostic imaging would have been done prior to coming into GRAC. But just for clarification and just so we're absolutely clear, like X-ray imaging, like they won't typically do any X-ray imaging or any diagnostic imaging within the clinic itself, correct? Not
within the clinic.
Okay. Okay.
These are all services that they can go towards, but not within the clinic space.
Okay, perfect. Do you have any special imaging that is performed outside of the clinical hospital?
It might be a question for Dr. Sampath, but not to my knowledge.
Okay, perfect. And then in terms of like getting the results back, I think a lot of the radiology reports would probably come back through PCIS currently.
Exactly.
Okay, perfect. And then they have their own ways of reviewing the images themselves.
Yeah.
Okay. Are there any routine tests that are required for every patient? For example, like if a patient comes in, is it required that if they're going preoperatively, they're preoperative, they get like a routine ECG or baseline ECG, for example?
That again will be a question for Dr. Sampath, but I think for in terms of GRAC planning, there are no routine tests that are required for the referral piece.
Okay, perfect.
Yeah.
Okay. And then again, other diagnostic tests, again, I think I'll just say that for Dr. Sampath, if that's the case then. Okay. Are there any diagnostic tests that maybe, okay, oh, thanks, Carmen. Yeah, I think that's it. And then diagnostic. In terms of diagnostic imaging, ED patients have the guys sent ED. I think we've actually done so all run already, Carmen, if you want to come forward a little bit there. Perfect. Well,
I think we have
okay.
all of that.
Okay, we have
We're
everything.
gonna
Perfect.
jump to order sets.
That sounds great. Thanks, Carmen. Okay. So again, please feel free to correct me to jump in at any point in time if I'm mistaken or I need some clarification, but we do not use any, so this clinic does not currently use any order sets per se. The order sets are usually embedded within the OR booking package, correct?
Yeah, and I think this is something I wanted to bring up today. I think in terms of from the order sets perspective, there are a few orders that would be needed for this clinic. And then in terms of power plan, I don't want to get ahead of myself, but I think there are two to three at least that the clinic would need. And that would the three of them would concern really the patient or the surgical pathways. So one for emergency surgery, one for community surgery, and then one for inpatient admission. I think ideally those would be the three power plans I have in mind. And then within those power plans, that could be hashed out when we engage with the surgical team. And then as well the surgical CFT engagements, because I think that isn't just a GRAC specific power plan, that would involve the whole surgical program and the
I
peri-op
see.
program.
Okay, so it would be beyond the scope of simply just the direct like understood.
Yeah, exactly.
Okay,
We'll probably lean on some of the power plans that come from those CST engagements. And I think the emergency, the community, and for inpatient admission, these are all very common paths that any surgical services could use within Richmond Hospital. So, but we'll ideally like to import those within GRAC.
Okay, perfect. I think we're good for this. Essentially, I'll just talk to this a bit later, but then at some point in time, I guess we'll be having an engagement session with the this order sets planning team, and then we'll get all the appropriate SMEs involved, as you know, and then we'll kind of hash out the granular details of what that look like and make sure that we have all the appropriate stakeholders involved in those meetings. So
For sure, yeah. The one thing I do want to call out is I think in terms of the order sets inputs and outputs, I think it's rather straightforward, and it's mainly just the transfer of patient location and status, right? Like we have the inpatient, or sorry, admit to clinic, we have referral to clinic, or in discharge, we have the referral to wound care clinician, and then we have all the other, clinical settings or status steps that's needed. But otherwise, I think from my perspective, there are no further special requirements, but I'll follow through that with the order sets team to call that out.
Perfect. That's great, and it's good that you definitely called up the separate streams that would be involved in these orders. So that's perfect. Yeah. So I think I essentially spoke to this. That yes, there will be like a gap analysis as well as a requirements gathering session to discuss what your needs are in the clinic, and from there it looks like we might have to kind of scale up and kind of bring other members involved and kind of discuss how these order sets can be implemented on a wider scale. So
that's good.
That's great. Yeah.
Thank you.
Perfect. Thank you. All right, Carmen, if you can go to the next slide, please. And then, oh, perfect. And then I guess I'll pass this back on to Carmen. Thank you very much for your time, everyone.
Thank you.
Yep. So I'll next just be asking some questions about report and billing. My understanding is that no reports are run, but are there, just to confirm, are there any reports that are run from this clinic? Others from what I understand was like you guys track the volume.
That's it. We want to track the volume. That's why we're using a PCIS location code, even though we don't have the template. I think ideally, if we know that there is a robust reporting function and that there are several parameters that we can report on, we ideally would like to build that out in the future. But as of now, we only track volume.
Okay.
Yeah.
And then these are questions, I guess it could be asked with Dr. Sampath as well, because it has to do with the provider, how they complete billing.
Feel free to ask.
fair?
I think Bal
Okay.
would have a great idea
Okay.
too. But I don't want to put that on Bal.
Okay.
I'll put Bal on the spot.
I'll ask.
Yeah.
But if not, we can always direct these to Dr. Sampath as well. So how
For
do
sure.
providers complete billing?
Bal, correct me if I'm wrong. For the billing part, it's basically we build that towards it's within the ACS budget, right? Like it's just a part of their ACS duties. So as long as they're on call, it kind of goes towards the billing pay. Is that correct, Bal? Okay, maybe we can save that for Dr. Sampath.
Okay.
Yeah.
Let me just double check something. Sorry. I think. Sorry. Just going back. Okay. So I'll save all those questions for Dr. Sampath and about the billing.
Yeah, but I think the overarching idea is that this is included within the ACS contracts.
Okay. All right. So just this is kind of an overview. We did do a crosswalk of the forms already, and generally most of the forms are already in Cerner, either in the form of like the regional OR booking forms, Inform Fast, consents Inform Fast, pre-admission information in PMO's registration, just part of the registration process,
Yeah.
progress notes and history. Yeah, I think you get the gist of it. We will build out orders for like the referral for the clinic and all that stuff. This was one of the admission questionnaires I was talking about, like the
Yep.
intake forms you have said that could be completed either by the patients that would have been sent out to them or with the surgeon
Mhm.
at the actual appointment. I was just wondering, are these questionnaires more for like the emerge referrals? Because if they were inpatient, would this information already been gathered when they were an inpatient? So I'm just wondering.
It's mainly the ED referral. These are all
Okay.
mainly the pre-op questionnaires that
Right.
they would need for so I guess for background and context, Richmond anesthesia will review every patient before surgery. So
Yep.
ideally, they would like to have this information as a part of the review, and this is really mainly for pre-op planning.
Okay.
Yeah, and as you mentioned, for inpatients, they would already have it, and for post-op follow-ups, they would have documented this already.
Thank you. That was it for my forms. So next is just a few just questions about research and clinical trials. I believe you guys don't run any clinical trials or participate in research, though. Is that correct?
No, we don't.
Okay, so I will skip that then. So next we're actually just going to go through kind of our understanding of the clinic and give a little bit of an overview. And then the design session, we will go over the future state. So this is our understanding of your current state. So the ED patient is diagnosed with ACS. Patient goes to the ED. Patient is diagnosed with ACS issues, and then this ACS team will be consulted. The ACS will consult on the ED patient in person or over the phone. ED then completes the ED referral form and completes diagnostic lab and tests that were as needed. ED then faxes the referral package to GRAC, and then the referral is processed by the program assistant and schedules appointment with the patient, unless it is a next day appointment, in which case they will report to RH main admitting.
Yeah, exactly. I think that's one point of clarification I would add, but otherwise it's very accurate. Thank you.
Yep. I actually addressed it in the next slide. So when the patient comes in, like at the day of visit, and this is a referral from ED, the patient will check in at RH main admitting, then wait in the the consult waiting area. And then the two forms, I will correct this because we have a better understanding of it now. Either it was sent to them and they would have completed these two forms already, or it will be done with the ACS provider. Either way, they will be seen by the ACS provider for review. The wound care clinician would also be seeing the patient as needed, and they would be coordinated with the ACS provider over the phone. And then from then on, the ACS provider will determine the next step of care, which includes the 4 pathways that you described, which I have in the next slide.
Yeah.
And this is an inpatient referral. So 3 North will fax the discharge order to the GRAC, and this will be a follow-up order written by the ACS provider. The program assistant will receive the follow-up request, and then they will book, the program assistant will book the post-op follow-up appointment.
Yeah, but I
with the
will,
patient. Yes.
if possible, I'll just call this a discharge referral if possible. But
Discharge referral. Okay.
very minute detail there.
No, thank you for clarifying. Okay. So next will be the inpatient referral, but their day of visit. So the patient will still check in at the RH main admitting and waits in the consult waiting or the GIM consult waiting area. The patient is seen by ACS provider. They are then seen, if needed, wound care clinician for wound care is needed. And then if the ACS provider decides they need more follow-up, they will communicate this to RE, who will schedule an appointment. If not, they will be discharged.
Yeah, for sure.
And that is what we understand to be your clinic workflow for this time. Do you have any more, or your team have any more questions for us?
Maria, do you have any questions?
No, not at the moment.
Thank you. Val? Okay, no questions from us, and I think this is very detailed, so thank you for preparing this and walking us through it. I guess the general question is like, what's next? Is
Yes.
it? Mhm.
Those are our next steps.
Mm.
So our next steps is a design session on July 21st, which I believe you guys should have had an invite already. It's from 9 to 12 p.m. And that session, Nicole spoke to it earlier, but we'll be talking about the future state workflows and also an in-system demo by our team, as well as a more formal like forms crosswalk, or showing you the future state of the forms as well. And then there will be another scheduling session. These, unfortunately, scheduling and the validation session will be scheduled much later in October, I believe, due to I think it was the capacity of some of the other team, just because we are working on another go live at UBC.
Yeah.
I believe that's my understanding of it. Please correct me if I'm wrong, team. But yeah, those are our next steps. Were there specific questions that you had about our next steps?
No, I think it's just there are quite a few engagements going through, and I know that Maria is also involved in quite a few things. So it'd be good within that description or that invite for July 21st, if you can just shoot us a short blurb on what that design session is about, and then just what the expectations are from your side and also for us in terms of preparation. That'll be handy for us.
Okay.
It's just really because there's so many of these, it's just easier for our team to track it.
Yeah,
Is that okay?
I believe we can do that. Yes. Thank you.
Perfect. Thank you.
Yeah.
Maria,
yeah.
any particular
Any-
ask or questions?
Oh, I think I'm okay with that. That will be a lot easier to prepare.
Great.
Yeah, in terms of action items and all that stuff, we will be sending out our minutes after we review them, and the slide deck as well. So
Perfect.
we will be in close contact with the team. Is there anything to add on our end, Nicole?
Nicole's unfortunately stepped away here.
Oh,
so
okay.
yeah.
If not, then thank you everyone for coming. That was a long time to be in a session for, so I appreciate everyone for coming and joining us.
Yeah. Sorry, I guess one last thing is I think you mentioned that there was an order sets engagement. Is that within the design session or is that separate? Or they'll book it with us?
I actually have to go find out if that can be one of my action items to go find out for you, and then I will email you with what I find out.
No worries. I'm just curious.
Yeah, no,
okay.
I am as well, to be honest. So
For
I'll find that out for you.
Okay, thanks, Carmen.
Yeah, thank you, everyone.
All right, thanks, everyone. Okay, thank you. Bye.
Thank you.
Thank you.